When we're listening with our stethoscope, so we've already done the rest of our examination, it's really important to palpate and observe first before we auscultate. The human speech area sits between about 300 and 2000 hertz in terms of frequency, and we've got up on the y-axis here, I'm pressing the wrong button, y-axis here, this is sound intensity and this is frequency. Sadly, as we age, the frequency with which we hear things starts to get lower. We tend to lose our high frequency hearing. If you map out where heart sounds occur, there's this sort of threshold of audibility, which is represented by this sort of orangey tan line coming down here. And a lot of heart sounds fall to the left and lower part of the screen to that and are inaudible to us. The main heart sounds that we listen to, so the S1 and S2 heart sounds, S3 and S4 heart sounds, which are easier to hear in horses than in dogs and cats, straddle that line. And ejection murmurs and harsher murmurs like those of mitral or aortic regurgitation are easier to hear. But a lot of heart sounds and murmurs kind of straddle this line of audibility. So we use our stethoscope to improve our audible range. And when you're using the stethoscope, the diaphragm of the stethoscope and the bell allow us to hear slightly different frequencies of sound. And if you've got a stethoscope either that has a head that you can turn the conduction tube round so that it's open to the diaphragm or to the bell, do use those two sides in conjunction with each other. You'll find, particularly in cats, you'll hear a lot more subtle sounds with the bell at lower frequency, particularly these sounds that are straddling the lower limit of audibility. It's important when you're using the bell that you don't press very hard against the chest wall, because what that does is stretch the skin out and creates a diaphragm, so you actually lose the benefit that you get of using the bell if you press too hard on the chest wall. But do use both of them, because you'll improve the range of frequencies of sound with which you hear. When we're listening, we want to auscultate on both sides of the chest, base and apex separately, and we want to listen for long enough. We're going to palpate pulses at the same time. And before we've done that, we've palpated the precordium, because again, you can't diagnose grade 5 and grade 6 murmurs without palpating the precordium. A lot of textbooks love putting pictures like this, where they've neatly kind of mapped out anatomically where the valves sit. Doesn't work like that. There's not something you can count intercostal spaces and know where the valves sit. What we do is we use audibility of sounds and where they're most intense to tell where we're listening. So when we are listening, the S1 heart sound is the onset of ventricular systole. Where that sound is loudest is over the mitral valve. So what we do is to palpate the precordium, feel where that first apex impulse is most intense. That's the starting point for listening with your stethoscope. And then you inch your stethoscope around until that S1 heart sound is the loudest, and you'll be over the mitral valve area. So we use auditory landmarks, not anatomical landmarks, to hear it. Where's it gone? So. Bump, 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 bump. So the first sound is the loudest. To find the heart base, so that's the apex, when we listen to the heart base, we want to inch our stethoscope cranially and dorsally into the axilla and listen to where the S2 heart sound is loudest. So it will come bam, 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 bam when we listen. And so it'll be so you get a change in cadence, so the second heart sound is loudest. There is not a lot of point in trying to distinguish between the aortic and the pulmonic valve sounds, because their sound profile will overlap in anything other than a huge dog. So if you've got a Great Pyrenees in front of you, you might be able to just distinguish those. But in the vast majority of dogs, their sound profiles overlap. So we divide it into just base and apex when we're listening. Or apex and base, you usually do them that way round. Also think about the timing. So when we're listening, we're thinking about the period of systole being bookended by those two heart sounds, the S1 and the S2 heart sounds. So systole in the middle, diastole, longer gap there. And if we're hearing abnormal sounds like murmurs, we want to listen to them in a way in which we're describing, are the S1 and the S2 heart sounds still present, or are they being occluded by that murmur? If we can't hear them, because all we can hear is murmur, then they're pansystolic murmurs. If they're occurring during systole, they're occluding the S1 and the S2 heart sounds. If we can still hear the S1 and the S2 heart sounds as distinct entities, and there's murmur in between, that's a hollow systolic murmur. Okay. And most commonly, the murmurs we'll encounter, so murmurs of myxomatous mitral valve disease tend to be plateau-shaped in profile and harsh, so they'll sound like this. And they're usually pretty audible. So the pressure difference between that left ventricle and left atrium is pretty high. The murmur will be almost always sort of grade 3, 4 plus when we identify myxomatous mitral valve disease. It's very uncommon to detect softer murmurs with myxomatous mitral valve disease. Conversely, murmurs that are associated with outflow obstructions, like this is an example of pulmonic stenosis. Okay, so we're looking at the right ventricular outflow tract here. We've got a stenosis, we've also got some insufficiency there, so you can see the flash going up towards the top of the screen, that's pulmonic insufficiency, but the big green flash going downwards is because this pulmonic valve is stenosed. And murmurs due to obstructions will tend not to be plateau-shaped in profile. They'll tend to accelerate and decelerate, and we'll get a sort of trapezoid shape or a diamond shaped profile where it gets crescendo and then decrescendo. So it sounds a little different, it sounds a little bit more it'll get louder and then softer as the murmur progresses. And those are discontinuous murmurs. Those are murmurs that are only present during systole. We might hear a continuous murmur. So this is a dog with a PDA. And because flow through the PDA occurs from the aorta to the pulmonary artery, unless it happens to be a reverse PDA, that flow will be continuous because the pressure in the aorta is always going to exceed that of the pulmonary artery. So it gets a little louder towards late systole, but it's generally there all the time. And it sounds very, very often referred to as machinery murmur because it sounds very mechanical in the background. The thing with murmurs of PDAs is they can be very focal. So probably the most common reason why murmurs of PDAs get missed is because someone hasn't listened right up in the axilla. They've not listened to the heart base properly, because the murmurs are always loud. They're always very, very loud murmurs, PDAs, but they can be quite focal. So unless you're consciously listening to apex and base all the time and palpating the precordium, because virtual PDAs are associated with precordial thrills, identifiable precordial thrills. So it's a really good habit to get into always doing that, particularly in puppies and kittens, because this is something you don't want to miss. This is an entirely curable congenital heart defect with an excellent prognosis if it's picked up. If they get to a stage where they're going to heart failure because it hasn't been detected, the prognosis starts to get much worse for recovery, and it's a very difficult thing for owners to cope with that, and they often are very, very cross.